Hello, smart Medicoz. If you love understanding how the body tackles really complex threats, you're definitely in the right place today. We're taking a deep dive into granulomatous inflammation. It's this, sophisticated but sometimes puzzling feature of our immune system. You see it in chronic diseases like tuberculosis, Crohn's. Our mission: understand how these microscopic sort of fortresses get built, what they tell us, and why they matter so much for diagnosis.
That's right. It's a really distinct type of chronic inflammation. Think of it as your body's very organized strategy to contain persistent agents it just can't easily get rid of. Our goal is definitely to unpack the fascinating details and show you how knowing this stuff really empowers, critical medical insight.
Okay, so granulomatous inflammation. When we talk about that, what exactly are we looking at? How is it fundamentally different from, say, other chronic inflammation?
Right, that's a key distinction. It's not just any chronic inflammation. It's highly organized, very specific. You've primarily got activated macrophages and T lymphocytes involved, and often there's this central area of tissue death, necrosis we call it. The whole point is to literally wall off agents that are stubborn, hard to clear, like certain microbes or maybe foreign materials. It's kind of like the body's last-ditch effort, building a microscopic fortress around something they can't beat otherwise.
A fortress. Yeah, that image really clicks. So who are the key cellular players in building this? How do they actually organize themselves?
I know. That's where it gets really interesting. The activated macrophages, they're the real stars here. They go through this pretty remarkable transformation. They become what we call epithelioid cells. They get bigger, lots of pink cytoplasm. They end up looking quite a bit like epithelial cells, hence the name.
Wow, so they actually change their shape, their form to become these building blocks.
Exactly, specialized builders. And then these epithelioid macrophages can do something incredible. They fuse together. They form these really striking multinucleated giant cells, the most famous type, Langhans giant cells.
Langhans giant cells, what makes them stand out?
Well, for one, they're quite large, maybe 40 to 50 micrometers across. But what pathologists really notice is the nuclei. They're arranged very distinctly, sort of pushed to the edge, peripherally, in a horseshoe or ring-like pattern. You can't miss it.
Okay, got it. And you mentioned T cells earlier.
Absolutely critical. Specifically, Th1 type T cell activation. Think of them as the chief orchestrator. They send out signals, especially interferon gamma, that basically supercharge those macrophages, pushes them into overdrive to build that wall. It's this intense collaboration that makes granulomas so robust, but sometimes it's also why they can cause significant local tissue damage. A bit of a double-edged sword.
So impressive structures, these fortresses, but what triggers them? Are they all formed for the same reasons?
Good question. No, not at all. We generally think about two main types. First, there are foreign body granulomas. These pop up in response to essentially inert stuff like talc powder or maybe bits of surgical suture left behind. There isn't really a specific immune response driving it in the same way, but you still see those giant cells and epithelioid macrophages surrounding the material. Sometimes that foreign material even looks different under polarized light microscopy, kind of refractile, which helps a pathologist spot it.
Okay. Inert substances. And the second type?
That would be the immune granulomas. Now, these are triggered by persistent antigens, often from microbes, and they absolutely involve ththose strong Th1-mediated responses we just talked about, with interferon gamma really driving that macrophage activation. Think classic infections like tuberculosis or maybe various fungal infections. What's also interesting is that sometimes, like with certain parasites, cystisomiasis is a good example, the body might switch gears and involve Th2 cells and eosinophils, a different kind of cellular army for a different fight.
Given these different triggers and cell mixes, do the granulomas themselves look different under the microscope? Are there structural clues?
Oh, definitely. The overall morphology is key. A typical immune granuloma usually has that central zone packed with epithelioid macrophages. Then there's usually a surrounding collar of lymphocytes, mostly T cells. And in older, more chronic granulomas, you'll often see a fibrous rim forming around the outside fibroblasts, laying down connective tissue. And yeah, you commonly see those Langhans giant cells mixed in there. But maybe the most critical difference we look for diagnostically is whether they're caseating or non-caseating.
Ah, caseating versus non-caseating. That sounds like a really important distinction for doctors. What do those terms actually mean?
They mean a lot. It's amazing how looking at that central core can point you in a specific direction. Case-eating granulomas have central necrosis that looks, cheesy. It's granular, amorphous, pinkish debris under the microscope. That's the hallmark of tuberculosis. See that, and TB immediately jumps to the top of your list.
Cheesy necrosis equals likely TB and non-caseating.
Non-caseating granulomas, as the name suggests, lack that central necrosis. The center is still packed with epithelioid cells and giant cells, but there's no dead, cheesy material. These are what you typically find in conditions like sarcoidosis or Crohn's disease, and also in those foreign body reactions we mentioned. So just recognizing the presence or absence of that caseous necrosis helps narrow down the possibilities quite significantly. It's like a microscopic fingerprint, almost.
Incredible detail. So identifying granulomas clearly limits the options. Why else is it so important diagnostically?
Well, finding granulomas immediately tells you you're dealing with a specific subset of diseases, but it always warrants caution. The absolute priority is typically to rule out an infection, especially tuberculosis, because it's treatable but serious. So you'll often need further tests, special stains for microbes like the AFB stain for TB bacteria, maybe cultures, PCR tests to look for microbial DNA, sometimes serological testing.
Right, makes sense. And we see these granulomatous reactions in quite a few real-world diseases, don't we?
We do. Besides TB with its case-eating granulomas and sarcoidosis and Crohn's, which are typically non-case-eating, you have things like syphilis, which can form gummatous granulomas. They often have lots of plasma cells mixed in, plus necrosis. And then there's cat scratch disease. That causes these really distinctive stellate or star-shaped granulomas with central collections of neutrophils, kind of like tiny abscesses within the granuloma. Each pattern tells a story.
It really sounds like a powerful containment strategy. But what happens long term? What's the fate of these fortresses once they form?
Well, the ideal outcome is healing, but granulomas typically heal by fibrosis, by scarring. And unfortunately, that scarring can sometimes be quite extensive. If it happens in a vital organ like the lungs or maybe lymph nodes, that fibrosis can actually lead to significant organ dysfunction over time. And, if the underlying trigger, that persistent antigen or microbe, isn't completely eliminated, the granulomas might just persist, leading to chronic inflammation or even disease reactivation later on. That's why getting an early diagnosis and starting targeted therapy is just so essential for you, the patient.
So we've seen how granulomatous inflammation is this highly organized, really quite remarkable attempt by the body to contain stubborn threats. But it can be, as you said, a bit of a double-edged sword sometimes, maybe overly aggressive.
Exactly. And understanding these distinct features from the unique cells like Langhans giants to knowing whether there's necrosis or not, it really empowers you to decipher some critical medical puzzles. It does raise a fascinating question, doesn't it? How often do our body's own protective mechanisms, especially when they have to go on for a long time, end up becoming part of the problem itself?